Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Kemi Obajimi. Today's episode features a pharmacist's perspective on how pharmacists can enhance comprehensive patient-centered care for patients with hormone receptor positive, HER2 negative metastatic breast cancer and pre-existing comorbid conditions. This episode is part of a larger educational program titled Comprehensive Patient-Centric Care in Hormone Receptor Positive, HER2 Negative Metastatic Breast Cancer, meeting the full spectrum of patient needs with comorbidities and related factors. This podcast features Dr. Allison Butts, Pharmacist Manager of Oncology and Clinical Pharmacist in Breast Oncology at the UK Healthcare Markey Cancer Center in Lexington, Kentucky. She will be reviewing comorbidities and complexities in managing patients with hormone receptor positive, HER2 negative metastatic breast cancer, the treatment landscape for these patients, data from real-world studies in women with hormone receptor positive, HER2 negative metastatic breast cancer, mitigation and management of drug interactions, and the role of the multidisciplinary team in treatment selection, maximizing quality of life, and achieving patients' treatment goals. For more information on Dr. Butts, along with a link to the complete program, including the associated downloadable slides, certified text modules, and certified video module, please visit the show notes for this episode. Now let's get started and hear what Dr. Butts has to say on this important topic.
Welcome, and thank you for joining this podcast, which is provided by Clinical Care Options in partnership with Practicing Clinicians Exchange and ProCE, and supported by an educational grant from Pfizer. I'm Allison Butts. I'm a clinical pharmacist specializing in breast oncology. I'm also the pharmacist manager for our oncology team at UK Healthcare Markey Cancer Center in Lexington, Kentucky. We'll start off by looking at some of the comorbidities these patients are affected by and some of the complexities involved in managing their care. This is a disease state that's typically seen in older patients. HR-positive breast cancer is diagnosed generally in patients over the age of 60. So already we're thinking about an elderly patient population that may have worse performance status and certainly other comorbidities that might come into play when managing their care. To call out a few of those, we think about diabetes now being a potential complication with some of the PI3K inhibitors that are on the market today. Patients with GI dysfunction may struggle a little bit more with some of the GI toxicities associated with these therapies. Inability to swallow is a problem, given that many of these new therapies are oral, so these complications certainly add up. Another one that I wanted to call out is cardiovascular disease. Specifically, we'll look at some evidence in the real world with patients with cardiovascular disease, knowing that they are oftentimes excluded from the clinical trial data. Polypharmacy is a major topic to think about when we're talking about managing these elderly patients, because we know that they are on multiple other therapies in addition to those that we're starting for their cancer treatment. Up to 5 to 7 prescribed medications are the average for our metastatic patients. And then we know about half of them are also on dietary supplements or herbal supplements that may not be outwardly reported to us. Of course, when we add chemotherapy and supportive care, we worry a lot more about drug interactions and other side effects that are compounding what therapies they're already on. The best solution that we know to overcome this is to do a comprehensive medication review and reconcile all those different therapies that a patient might be on. Pharmacists are critical in doing this. We know that pharmacists, based on data, have a better track record with doing medication reconciliation and getting a more accurate drug list. We could also employ our pharmacy technicians to help obtain these medical histories, and that seems to be a better solution than relying on our nursing colleagues or physician colleagues to do a similar task. Pharmacists can certainly get that active list correct, but that also helps us to identify drug interactions and remedy those. We can reduce visits to the emergency room and hospitalization visits by better identifying medications that the patients are on, and really help to be an advocate for the patient throughout the course of their care in that regard. Those of us who practice in clinical practice are aware that there are limitations to being able to really provide a robust medication reconciliation program, and that could be based on time constraints, staffing limitations, or even space logistical considerations. So what are some things that we can do to try and overcome these? We could use IT to our benefit. So we could use dispensing records that are available through many of our EMRs to help get a good list at baseline for our patients. Keep in mind that OTC and herbal medications are not on there, so we still need to do some extra work to gather a complete medication list. We could also use our IT systems to help us identify drug interactions and use some of that clinical decision support technology that's available today. But really, it still takes a fair amount of time and expertise to really make sure that we are managing polypharmacy effectively. At this point in time, CDK4/6 inhibitors, ribociclib, palbociclib, and abemaciclib are standard of care in the first-line setting for metastatic HR-positive breast cancer. And this is true of patients who have de novo metastatic disease and patients who have a previous history of breast cancer but are far away from their prior adjuvant therapy. But it's also true of patients who maybe are still completing their adjuvant therapy when they have a metastatic recurrence. So very predominant drug class, the CDK4/6 inhibitors that we see across the board in our HR-positive metastatic breast cancer population. A newer therapy that's come to market just in the last 6 months or so is a 3-drug combination that again includes a CDK4/6 inhibitor, specifically palbociclib, this time in combination with fulvestrant and inavolisib. So this regimen is newer, and as we'll discuss, carries a bit more toxicity than some of the other regimens. But those 3 core regimens are important to be aware of for HR-positive management. Looking at some of the toxicities amongst these various drugs in the same drug class, the most important toxicity to keep in mind from a class effect is neutropenia. So across the board, all 3 of our CDK4/6 inhibitors are notorious for dropping blood counts and require frequent monitoring of our patients. Think about this elderly patient population, maybe some of these patients who are pretreated, that neutropenia could be exacerbated perhaps and be a consideration for selecting these therapies. Fatigue is the other class effect. Thinking about some of our older patients, those with a lot of comorbidities, that might be a factor that could really be more impactful. Specifically for palbociclib, there's not a lot of additional toxicities outside of the neutropenia and fatigue that we need to monitor on a regular basis. So that makes it probably the best tolerated for our patients with significant comorbidities. Ribociclib adds the side effect of QT prolongation. So we do have to monitor patients' QTC intervals with an EKG at the start of therapy. So that is an important consideration. LFT monitoring is also necessary for ribociclib. And then lastly, abemaciclib tends to carry the most side effects, the most tolerability issues, because now we add diarrhea and abdominal discomfort as a very common toxicity seen with abemaciclib. So if we're thinking about our patients with comorbidities, that might be an important one to take into account when selecting between these 3 different agents. LFT monitoring is necessary as it was with ribociclib. So both abema and ribo required additional monitoring of the liver function. And there's also more reports of VTEs and ILD with abemaciclib. Circling back to our newer 3-drug combination, inavolisib with palbociclib and endocrine therapy. As I mentioned, there's more side effects with this regimen because now we're adding an additional therapy in inavolisib, which is a PI3K inhibitor. So what we see now is our typical side effects from the palbociclib, again, being neutropenia and fatigue primarily. But the inavo also adds some notable toxicities such as mucositis, hyperglycemia, more diarrhea, and even potentially some ocular effects that could come into play when evaluating a patient's comorbidities in treatment selection. So knowing all of this data from the clinical trials, how does this fare with real-world data, and how can a multidisciplinary team really work together to overcome some of these issues? Cardiovascular disease is a typical exclusion criteria from the clinical trials, including those for the CDK4/6 inhibitors. So that is a really good reason to look at some real-world data specifically in that patient population. One study looked at 2 available drug databases, the Truven database and the Optum clinical informatics database, to try and estimate the proportion of patients with HR-positive metastatic breast cancer who may be at risk of QT prolongation, the biggest concern with ribociclib. And so the study looked at a number of risk factors to try and quantify the predominance of this. So they included congenital long QT syndrome, some electrolyte abnormalities, and cardiovascular disease to try and assess the impact. Overall, about 1 in 3 women with HR-positive metastatic breast cancer have a risk factor for QT prolongation. And that risk increases with age. So those who are over the age of 75 certainly have more risk factors for QT prolongation than those who are younger. But on average, about 1 in 3 of our patients are potentially impacted by these risk factors for QT prolongation. Add to this medication therapies that are known to prolong the QT as well. So things like antibiotics, vasoconstrictors, some of our antiemetics. You could see that this impact potentially adds up very quickly and needs to be evaluated and mitigated when starting a therapy like ribociclib. Another important piece of real-world data is the P-Reality X trial, which sought to determine the real-world effectiveness of first-line palbociclib with an aromatase inhibitor versus an aromatase inhibitor alone. So it's taking patients who are perhaps more reflective of our real-world patients that we see in clinic every day to see how the data compares with the original Paloma trial that led to the approval of palbociclib. So the results of the P-Reality X trial show that patients with HR-positive metastatic breast cancer, as well as cardiovascular disease, received treatment safely with palbociclib and an AI, and it improved their progression-free survival as well as their overall survival when compared to the AI alone. So the reason that this is particularly notable, I think, is that the Paloma 2 trial did not find a statistically significant overall survival benefit, but the real-world data did. It's hard to compare different trials, but this real-world data includes patients with cardiovascular disease that were not necessarily well represented in the original data. So very interesting results to take into consideration that maybe the clinical trial data isn't telling the full story when we incorporate more diverse patients into the equation. The pharmacist specifically can do to help impact the care of these patients. We know that up to 70% have other chronic diseases that are going to come into play in addition to the malignancy that we are treating. We also know that about half of our patients are taking medications for other pre-existing comorbidities that may interfere in some way with cancer therapies. So the pharmacist has a very important role to play in terms of mitigating these drug interactions, managing toxicities, both from their standard therapies that they were on prior, as well as their cancer treatments, and really trying to limit treatment duplications to lessen the impact that this can have. Other roles that the pharmacist can play are multiple. So supportive care is a big area that pharmacy gets involved with, whether that's pain management or symptom management from their therapies such as nausea, diarrhea, skin rashes, etc. Adherence and compliance is a big area for pharmacy intervention with providing follow-up appointments and adherence checks with our patients. We all have a role in clinical trial and research management, so helping to identify patients for clinical trials, but also being able to look at how our patients compare to the clinical trial population. Implementing an effective multidisciplinary team process is important for the pharmacist to be involved with as well. We tend to be very good communicators, and a common link that could reach out to multiple different groups to ensure that medication is being handled appropriately. Patient education and counseling is a major part of what I do on a daily basis to inform the patient on what to expect from their therapies, how to take it, and provide any additional support or resources that they may need. And then finally, medication management's really at the center of everything we do as well. So whether that's being involved in treatment selection and dosing, as well as managing, again, some of these toxicities and drug-drug interactions that are common with our patient population. We know that all of the CDK4/6 inhibitors are CYP3 substrates, so we need to be careful that we are avoiding strong CYP3 inhibitors and strong CYP3 inducers to make sure that the patients are getting the medication safely and effectively. We also need to be aware of the QT prolonging drugs. This is specific with ribociclib. So if a patient is going to be starting on that agent, we want to make sure that a pharmacist is doing a good review of their medication list and ensuring no potential issues there. So looking at QT prolongation, we know that there are multiple therapies that could show up on that medication list that could lead to trouble with ribociclib. That could be antiemetics, antidepressants, antihistamines, many drugs that could potentially prolong the QT interval and interfere with ribociclib toxicity. Adding to that, though, there's other complications from cancer treatment itself, like dehydration and electrolyte abnormalities, that might further exacerbate the QT prolongation risk. All needs to be considered with frequent interventions and communication with the patients as well as the care team. The patient really needs to be at the center of all these interventions, and we know that there's not a one-size-fits-all solution to treating any condition, especially metastatic breast cancer. We need to be taking into account the patient preference for both setting treatment goals as well as achieving their goals, because we know that each situation is different and patients have different preferences, different values, and various other circumstances that need to be considered in terms of their management. We need to make sure that we're balancing the effectiveness of the treatment versus what the risks are and what the quality of life implications are for each individual patient. And oftentimes doing this requires a multidisciplinary team of different experts. It could be different physicians like a cardiologist, a gastroenterologist, endocrinology, et cetera, to help reach out for some of these more complex toxicities, as well as maybe talking to them about their pre-existing conditions and how we might be able to optimize those a little bit better. But within the clinic team itself, making sure that the pharmacist is working closely with the nurse navigator, the medical oncologist, APPs, social workers, genetic counselors. The list goes on in terms of the number of people that we interface with in order to optimally care for these complex patients. A few final thoughts are that patients with HR positive, HER2 negative metastatic breast cancer tend to be elderly and carry a fair number of comorbidities that need to be managed. With this, polypharmacy is a major topic that needs to be discussed with the care team as well as the patient to make sure that we are optimizing their therapies as best we can. Some endocrine therapy combinations carry toxicities that overlap with other medical conditions. So if those are not well managed, we might need to interface with their other providers to work on that before we add additional adverse effects and other factors that are going to make the situation potentially worse. Pharmacists play a major role in managing drug interactions and toxicities, and we need to be aware of how to optimally address these polypharmacy issues because we're oftentimes the expert and the ones best suited to do a lot of those tasks.
Thank you very much, Dr. Butts, and thanks to you, the listeners, for joining us. As a reminder, to view the full program on comprehensive patient-centric care in hormone receptor positive HER2 negative metastatic breast cancer, meeting the full spectrum of patient needs with comorbidities and related factors, on the Clinical Care Options website, please click on the link in the show notes. As always, thank you for listening.